Good afternoon, and thank you very much for the opportunity to speak at this year's World Congress of Anaesthesiology. It's sad not to be in Prague as planned, but it's great to be able to contribute to this fantastic online conference. So my job now is to talk about achievable goals for the next World Congress in Perioperative Medicine. And in fact, I've taken a few liberties with the title and changed that to what are the achievable goals for 2024? Because our next World Congress is now only 3 years away. And I've expanded perioperative medicine to cover perioperative care for reasons that I hope become clear during the talk. And what I'll endeavour to do is make these goals SMART, i.e. specific, measurable, achievable, realistic and timely. Measurable may be a little bit challenging given that this talk needs to be relatively generic for a whole variety of different contexts, but hopefully I'll meet the other criteria. So there are a couple of caveats. We live in challenging time. Difficult bugs, or more correctly, a difficult virus, COVID-19, has really disrupted both our professional and personal lives over the last 18 months. And not only is it disrupted the delivery of healthcare, it's disrupted spending at a national level and therefore economics and the potential funding available for the future delivery of healthcare. And it's also been a huge drain on healthcare staff. So there are major issues around well-being and resilience of the staff who might be delivering any goals for the next 3 years. Having said that, I'm an incurable optimist. I don't know what you see here, but I see a glass that is definitely half full. And whilst we have challenges, so we have challenges from the legacy of COVID-19, both in terms of healthcare and economically. We have the challenges that were there before COVID-19 came along. So the demographic profile with an increasing aging population, the challenges of multimorbidity due in significant part to what one could describe as self-harm. So human behavior in terms of smoking, alcohol, inactivity, poor diet and obesity that contributes massively to the morbidity that we see. And then the challenge of innovation-driven demand growth. So completely new things that we couldn't do, say, 25 or 50 years ago that are now driving increased costs of healthcare. So the knee replacement being a great example. Didn't exist more than 50 years ago and now is incredibly common and delivering incredibly widespread symptom relief for so many people. And all this within the context of inevitable health economic constraints with essentially unlimited demand and a limited pool of money. Now we can see these as challenges, but equally we can see these as opportunities that drive a real need for change and improved efficiency in perioperative care. And we have a variety of solutions available to us. We can and should be, and indeed many centres are, rethinking how healthcare is delivered, thinking about who is delivering which interventions, what interventions, where they are delivering them. Should we be spending so much time focusing on secondary and tertiary care when actually an awful lot of a patient's life, most of a patient's life goes on in the community, and how do we deliver them? Which type of practitioner might deliver these interventions? The notion of redesigning pathways so that they're much more patient-focused rather than provider-centered. We have typically structured our healthcare systems for the convenience of the providers more clearly than for the convenience of the patients. And then the notion of removing barriers, both professional barriers and disciplinary barriers, to ensure that the patient focus is translated into the right thing being done rather than worrying about who does it necessarily. And I think we have a clear burning platform. There is this data from before COVID suggesting that surgery and the consequences of surgery, in this case 30-day mortality, is one of the leading causes of death, the third leading cause of death, in fact, globally, exceeding the total mortality from TB, malaria and HIV in any given year. And added to that, the challenges of COVID. So this is some modelled data from the COVID Surge project based on the first 12 weeks of the pandemic. So March, April and May last year, suggesting that nearly 30 million operations had been cancelled, 2.3 million cancer surgeries had been delayed, and we're now 18 months in, not 12 weeks in. So the consequences of COVID for our elective surgical activity, and our referral pathways have, as we all know, been absolutely massive. Alongside that is an increasing appreciation that the determinants of health, the determinants of ill health, are not just about what we do as healthcare professionals. In fact, that's a relatively small contribution to the variation that we see, but they're also about the behaviors that our patients and we ourselves exhibit in terms of, for example, smoking and drinking, activity and exercise. And they're about the environment that we live in and the socioeconomic and physical environmental factors. And that's why we increasingly think in terms of this triple aim. So not just focusing on the individual in front of us, the patient in front of us, but also addressing our concerns to the health of the population in general and how we can contribute to improving that, and recognizing that we have responsibilities in terms of the costs of the interventions. If the economics don't stack up, there's a limited pool of resources. If we're not contributing to make what we do as cost effective as possible, then we won't be able to do something else somewhere else in the healthcare system. And perioperative medicine really addresses these aims well, meeting the patient experience in terms of quality and satisfaction with care, addressing the health of populations, and I'm thinking here particularly of prehabilitation and rehabilitation following surgery, and also addressing financial efficiency, so minimizing the per capita cost of different interventions. And I'm going to address these issues through 5 simple assumptions that I find really useful when thinking about perioperative care. The first is that as a patient, I would expect to be a partner in my own care, and therefore I would expect to be involved in decisions about 4 things: that the right decision had been made about having surgery, that surgery was the correct course of action, that I was properly prepared for the surgery, I was in the best possible state I could be, that the quality of care whilst I had my surgery and anaesthesia and post-operative care would be the best it could be, so the least possible harm during my hospital admission, and that I would fully recover, essentially back to where I started, but minus whatever the pathology was. And we have a repertoire of means of addressing these questions. So through shared or collaborative decision making, we can ensure that the right decision is made, and that perhaps surgery isn't the right course of action, perhaps chemotherapy for a malignant condition, perhaps physiotherapy for a joint pathology. Through prehabilitation and morbidity management, we can ensure that patients are well prepared for surgery. And then through the most effective conduct of anaesthesia and surgery, we make sure that they're well cared for during their operation and that they recover as fast and as effectively as possible. Now, this may all feel a little bit pie in the sky, but we've done some of this already. This is the great Henrik Kellett, protagonist of Enhanced Recovery, and we managed to change pathways. We managed to change the way that perioperative care was delivered across whole countries. This is just an example. Henrik, obviously not originally from the UK, but this was adopted as a national target within the UK, within the National Health Service, and extraordinary improvements in hospital length of stay and quality of care were achieved within an 18-month structured program. So we can do this, which brings me on to my achievable aims. The first one is to put the patient at the center of everything that we do. The second is to reach out across professional boundaries, to worry less about who is doing whatever is being done, be it prehabilitation or recovery following surgery, but worrying about doing it in the best way possible as a team, as a multi-professional team. The third is to worry about the money, justify the expense, think about the cost effectiveness of the different things that we do, and aim for innovation-driven efficiency growth rather than innovation-driven cost growth. So the innovations that we have improving efficiency rather than simply increasing cost. And finally, and probably most importantly, to change the culture in which we work so we ensure that we are working as a team, that we build a team around us and that we all contribute together to those other goals, putting the patient first, working across professional boundaries, worrying about financial constraints, looking for innovation that drives efficiency, and working as a team. So if we do all this, I hope that we'll come back in 3 years' time and feel a little bit like this, with our cup overflowing. Maybe that's the incurable optimist in me, but I think we have real opportunity at this time through perioperative care to change the care of our patients for the better. Thank you very much for listening, and I'd be delighted to take any questions by email or via Twitter. Thank you.